Oops. So as we've heard for the last couple of days that the proteasome is very important for plasma cell biology, and proteasome inhibitors, despite all the studies on mutations and everything else, are the cornerstone of treatment for multiple myeloma. And the first class, of course, bortezomib, has shown major advantages and major changes in the treatment of our patients with myeloma. Now, the proteasome has two different types, the constitutive proteasome and the immunoproteasome. The immunoproteasome is usually in the immune cells, but can be activated in other cells, including the plasma cells. And as you can see here, the most important part of the proteasome that is required for the catalytic activity is the chymotrypsin-like activity. So there is the trypsin-like and the chymotrypsin-like, as well as the caspase-like activity of the proteasome. I'll get that right. Now, the second class of agents that has been developed for proteasome inhibitors has been carfilzomib, and you've seen very nice data previously in clinical trials for carfilzomib as a single agent or in combination for multiple myeloma patients. If we go at higher doses, and this is courtesy from the Onyx team showing me that at higher doses of 56 milligrams per meter square, you can completely inhibit the proteasome, especially the chymotrypsin-like activity of the immunoproteasome as well as the constitutive proteasome in cells of multiple myeloma patients. However, the development of carfilzomib was IV, and when they originally developed it, they wanted to do 5 days on continuous, but it was very hard to do that for patients, bringing them every day for 5 days. So the question came, can we develop oral agents that can give you the same proteasome inhibition and can potentially give you that benefit of giving it for 5 days? And the Onyx team had went back and tried to develop with the same class of agents, taking carfilzomib and taking the epoxy ketone part, the warhead part of it, changing the structure so that you can add a tripeptide analog and try to develop it as an oral agent. And they went through 500 molecules trying to see as a cell-free or a drug cell-free assay, trying to see if you can inhibit indeed the chymotrypsin activity. And finally, they found a few compounds that indeed are active to inhibit at less than 100 nanomolar the chymotrypsin-like activity of the proteasome. They went on and tested it in mice, and you can see here all the different activities of the proteasome inhibitors that they tested, and indeed you can have activity with inhibition in the blood, in the heart, and adrenals of those mice, with some of those agents having good bioavailability versus the other ones that they had tested with poor bioavailability. And finally, they came up with the oprozimib or Onyx 0912 that we're talking about today. Now, Dharminder Chauhan with Ken Anderson has shown beautifully that in multiple myeloma, Onyx 0912 or oprozimib can indeed have significant activity in multiple myeloma, not only on the plasma cells, but also can have activity on angiogenesis, on osteoclasts and osteoblasts. As you can see here, the caspase inhibition, which is apoptosis, factor 8, and VEGF inhibition with the angiogenesis, and showing you indeed that this can be active in multiple myeloma in mouse models. The team has also shown previously that this drug can be active not only in multiple myeloma, but also in solid tumors, which is an interesting area, as well as in non-Hodgkin's lymphoma, where you now can take it not only for proteasome inhibition in multiple myeloma, but also in other potential diseases, as well as solid tumors. Now, here's the bone anabolic activity of the proteasome. You've heard already about bortezomib having anabolic activity. Carfilzomib has the same activity. And here, this is data showing you that also oprozimib can indeed induce osteoblastic activity and inhibit osteoclasts, so that the agent is not only working on myeloma cells, but also working on the tumor microenvironment. Aldo Rucaro from our group has also shown that indeed Onyx 0912 or oprozimib can also work on Waldenstrom cells. And Steve Trion has shown you previously how Waldenstrom is a disease that has distinct biological features that are different than other plasma cell disorders. And indeed here, oprozimib is showing us activity in vivo in mice, as well as in cell lines, having caspase cleavage, as well as significant inhibition of proliferation and apoptosis in the Waldenstrom cells. So if we look at the differences between carfilzomib and oprozimib, one is IV, one is PO, as we know very well. The 80% proteasome inhibition is achieved with the oprozimib at 30 milligrams per meter square. The single dose MTD in the rats and monkeys, or rats and dogs here, is 300 milligrams per meter square. And again, this is one potential area where you can use it QD times 5, where it was harder to do with carfilzomib. Now, the DLT is very different between carfilzomib and oprozomib, where oprozomib, because it's an oral agent, most of the proteasome inhibition is in the GI. And again, here, most of the activity and most of the DLT toxicities were indeed in the GI part. And you will see in the clinical data that this is exactly what is being reflected from the preclinical data that was done. Hematologically, the main problem, again, with toxicity was thrombocytopenia, which is exactly what we see with other proteasome inhibitors. And then as clinical chemistry, there was no pre-renal azotemia in the oprozomib with the rats and dogs studies that was performed. So we'll go on with the clinical profile of oprozomib, and this is the single agent activity data that was presented in the American Society of Hematology in December, and the cutoff of data was in November, so this is what I will be presenting today. Further studies and further patient information, including toxicity and response, will not be presented today, but I'm sure it will be presented further on in future studies. So this is on behalf of all the investigators in this study. I will show you some of the data of the phase 1b/2 study of single-agent oprozomib in heme malignancy. So again, at the cutoff of November 2013, 57 patients were treated on this study, 37 with multiple myeloma, 18 with Waldenstrom, 1 with mantle cell lymphoma, and 1 with plasma cell leukemia. Different cohorts were tested, and different dose modifications and different doses have been tested. Again, there were 2 major schedules that we are testing with oprozomib. One is the 2 out of 7, so 2 days out of 7, and the other one is 5 out of 14, and I'll show you some of that in the next few slides. Almost all of the patients, or actually 60% of the patients, had prior exposure to bortezomib, and 54% of those patients were bortezomib refractory or relapsed after the treatment with bortezomib. The median oprozomib treatment exposure was 15 weeks when you look at the ones who had the 2 out of 7 schedule, while it was 10 weeks at that time with the 5 out of 14 schedule. So here is the dosing schedule for the 2 out of 7 or 5 out of 14. So for those who have not used oprozomib, we're giving it just like carfilzomib, 2 days on every week, so days 1, 2, 8, and 9. And you repeat this cycle every 14 days with the 2 out of 7 schedule. For the 5 out of 14 schedule, it's 5 days on, and then the rest of the 2 weeks is off, so 5 out of 14 schedule. And you can see here we started with 150 milligrams, and we went on to 330 milligrams in both schedules, or at least the trial was designed to go on with both schedules up to 330 milligrams. And you can see this is the different types of patients at the cohorts escalation with the 2 out of 7 or the 5 out of 14 schedule. This is the patient demographics. Again, the font is small, but I'll guide you through it with the 2 out of 7 schedule as well as the 5 out of 14 schedule. And you can see that 18 patients with myeloma were treated on the 2 out of 7, 19 on the 5 out of 14. Most of the Waldenstrom patients were treated on the 5 out of 14, but there were 7 on the 2 out of 7. Risk stratification by ISS, you can see here that there was about 9 patients here on the 2 out of 7 and 7 on the 5 out of 14. And then the prior regimens that they've had, the median was 2 lines of therapy, with some of them having 8 prior lines of therapy, and in the other group with 5 out of 14, up to 10 prior lines of therapy or 12 prior lines of therapy. So many of those patients were indeed heavily pretreated with multiple agents before therapy. Again, we've talked about whether they were bortezomib refractory or not, and you can see here 13 patients were bortezomib refractory, 6 in the 2 out of 7 arm were bortezomib treated or refractory to prior bortezomib therapy. If we look at the dose-limiting toxicity, and again, this is the data from the cutoff of November 2013, you can see that we had reached the DLTs in the 300 milligrams in the 2 out of 7 schedule with hypotension and diarrhea, 1 patient in each group. In the 5 out of 14 schedule, there was 1 patient at the lower dose, 180 milligrams, with renal failure, 1 with tumor lysis, which again usually indicates activity, fast activity of this drug, and then 2 2 patients with tumor lysis as well as vomiting at the 270 milligrams. The maximum tolerated dose was achieved with the 5 out of 14 schedule at 240 milligrams. At the time of analysis of this, and again, this will be updated further, the MTD was not reached for the 2 out of 7, but it has been reached now. Now, here is some of the treatment emergent adverse events. The first part here is the hematological toxicity, and the second part is the non-hematological toxicities, and it's broken down for you by the grades. And you can see here the grade 3s and 4s are highlighted in the red and green. Again, anemia and thrombocytopenia are very typical for proteasome inhibitors, less so for the neutropenias. And you can see here again, the grade 4 thrombocytopenia were 12% in the 5 out of 14. The 2 out of 7 had less adverse events compared to the 5 out of 14, as you can see here in all of the measurements. But again, the grade 4s were typically thrombocytopenia as well as some of the anemias. The major toxicities that we see as non-hematological toxicities with oprosumab are again the GI toxicity, and this was expected from all the studies that were done previously because of the proteasome inhibition in the GI. So again, we see the nausea, diarrhea, and vomiting are the major ones that we see, and there are lots of trials now to see how we can change that challenging part of the toxicity with oprosumab. But you can see here that mainly, again, all of these are GI toxicity. Some of it, again, the non-hematological toxicity that's not GI is fatigue, as well as the creatinine increase, and then headache, insomnias, and dizziness. The SAEs, again, in summary, for the 2 out of 7, 24% of the patients had SAEs, while in the 5 out of 14, 21% of the patients had SAE. And at the time of cutoff here in November of 2013, again, there were no deaths observed on this trial. Treatment discontinuation in the 2 out of 7 schedule, 20% of the patient had discontinued because of progression, and the other patients either because of patient decision or investigator decision at that time. And across all dosing cohorts, 3 patients had more than 1 dose reduction. For the 5 out of 14 schedule, almost 50% of the patient had discontinued therapy, less so for progression, but more so for either toxicities or for patient requests. And then there is about 12% for disease progression. 12 patients, which is 37% of the patients, had dose reductions with the 5 out of 14 schedule. If we look at the responses, and again, this is single agent activity without dexamethasone, we can give 4 milligrams of dexamethasone for the nausea, but not more than that. You can see the 2 out of 7 schedule and then the 5 out of 14 schedule. I will just highlight the overall response rate here for you. In the 2 out of 7 schedule, 13% overall response rate, including 1 VGPR, 1 partial response, and 3 minimal responses. And if we look at the clinical benefit rate, it was 33%. The 5 out of 14 schedule was a much higher response rate in those patients, and again, because of a longer proteasome inhibition, and you can see that reflected in the overall response rate, 27% overall response rate, 5 out of those patients, 33% clinical benefit rate, and you can see here again, 11% VGPR, 16% partial response, and 5% minimal response, with almost 40% of the patients having stable disease. Now, if I take you to Waldenstrom, which is not analyzed in the prior part, and this one had an 80% response rate and not 28% response rate as in multiple myeloma, you can see here this is a breakdown of the first patients that were treated on this trial, and again, we have expanded this further, but you can see here that almost all of the patients had a significant IgM reduction, 1 complete remission at the 180 milligram dosing, and then many other partial remissions with 1 minimal response at the time of the analysis of this study. Here is one case just to highlight the complete remission that has been observed in Waldenstrom. This is a 60-year-old patient who had prior therapy with Rituxan and again was minimally treated previously, but had an IgM level of 1,200 milligrams per deciliter, 30% involvement of Waldenstroms in the bone marrow. And you can see here within just a few cycles at a lower dose of oprosumab, 180 milligrams, the patient achieved a complete remission and is ongoing now with a complete remission over 1 year with a very well-tolerated dose of 180 milligrams. This is just showing you hematocrit response in those patients, as well as we have the bone marrow responses in those, as well as lymph nodes responses in almost all of those patients. And you can see here, indeed, there is a significant increase in hematocrit response along with their bone marrow and lymph node response with Waldenstrom. So in conclusion, oprozumib in the 5 out of 14 schedule, the MTD was reached at that time was 240 milligrams. The 2 out of 7 schedule at that time was not reached for an MTD, although it has been reached now. The most common hematological toxicities, which are anemias and thrombocytopenia and neutropenia, is expected from proteasome inhibitors. I think the more challenging part is the non-hematological toxicities with GI toxicity, and if this can be managed, then potentially this can help a lot with the further development of this agent. There is the addition of dexamethasone that can help, addition of other anti-emetics, and potentially management of the GI toxicity can help. And I can tell you at Dana-Farber, our research nurse has been wonderful doing a very aggressive measurement of our patients and very aggressive help to help them tolerate that GI toxicity. No grade 2 or more peripheral neuropathy has been observed. So again, this is very similar to carfilzomib, that we're not seeing emergent peripheral neuropathy in this. And again, comparing it to ixazomib, minimal grade 1 rash was observed in those patients. Again, at the dosing more than 240 milligrams per day, you can see significant inhibition of proteasome as much as the carfilzomib that you see with IV carfilzomib at the regular dosing. And the clinical profile looks promising for multiple myeloma as well as Waldenstrom, with 27% response rate in multiple myeloma in the relapsed refractory setting as a single agent, and over 80% response rate in Waldenstrom, again as a single agent in the relapsed refractory setting. Phase 2 data is ongoing right now in those patients, and further development and further data will be shown in the next studies. So with that, I'd like to thank many investigators, of course, all the people who put patients on the clinical trial. I'm highlighting some of them here. Of course, the DFCI MGH investigators also who have put many patients on the study, and then the DFCI clinical research team, especially our research nurse, who basically gets calls every day to try and manage all the toxicities that we observe and try to help those patients through their work. And thank you.